Good morning, respected teachers and my dear colleagues. So, starting with the today's case, a 53-year-old male farmer from Bharatpur presented us in the OPD with the complaint of right flank pain since 3 months. Patient was apparently well 3 months back. Then he had started having pain over the right flank, which was incidence is onset and dull aching in nature. And it was relieved by taking some medication at the home. Pain was non-radiating and there was no aggravation of pain like food or changing of the posture. Patient did not have any history suggestive of lower urinary tract symptoms, hematuria, dysuria or the passage of stone per urethra. There was no history of trauma to abdomen, no history of fever with chills, anorexia, nausea, vomiting and dyspepsia, and there was no history of any significant weight loss. Patient was non-case of type 2 diabetes mellitus since 8 months and taking tablet metformin 500 BD for the same. Patient also diagnosed with pulmonary tuberculosis with tubercular meningitis and on anti-tubercular medication since 8 months. There was no history of any cardiac compromise in the form of hypertension or any coronary artery disease. Patient is strictly vegetarian with the normal sleep and bowel bladder habit. There is no history of any addiction or no history of any specific drug or food allergy. So personal and family history, nothing contributory in this case. On general physical examination, patient was conscious, cooperative and well oriented to time, place and person, was hemodynamically stable and afebrile. The weight is 130 kg and height of 165 cm. So BMI of 47 kg per meter square. So according to WHO classification, our patient is morbidly obese. There was no pallor icterus or generalized lymphadenopathy. On abdominal examination, on inspectory finding, abdomen was protuberant with no any visible scar or pulsation. Umbilicus was centrally placed and normal. No visible peristalsis or engorged veins. On palpation, abdomen was soft, non-tender, no organomegaly and hernial sides were normal. On percussion, tympanic knot present all over the abdomen and the dull knot was present in the flank. On auscultation, normal bowel sounds were heard in all over the quadrant and there was no abnormal bruit. External genitalia found to be normal. On digital rectal examination, anal tone was normal. No any prostatocmegaly, no active PR bleeding or no any mass felt in rectum. The CVS examination, respiratory examination and the CNS examination are normal. On laboratory investigation, CBC, LFT, RFT within normal limit except mild dyslipidemia and as patient is diabetic, the random blood sugar is 207 mg per deciliter and HbA1c of 7.3. So, to summarize this case, we have 53-year-old male, morbidly obese of BMI 47, diabetic patient taking tablet metformin and on anti-tubercular treatment for tubercular meningitis and presented us with the right flank pain since 3 months and on clinical examination, there was nothing significant. So, I just want to ask my fellow colleagues, what should be the possibilities in this case, if anyone? Yes. Okay, thank you. Anyone? Yes. Okay, very good. Or? Yes. Okay. Now let's see. So, based on the history and clinical examination, the clinical possibilities either obstructive, infective, or it could be neoplastic. So, in the form of obstructive causes, generally we encounter in our urological OPD, most causes are renal or uretary calculus. Other causes include pelviureteric junction obstruction or there might be extrinsic compression by the enlarged lymph node. As we know the patient is diabetic, so infective causes should be ruled out like acute pyelonephritis, emphysematous pyelonephritis or pyonephrosis. But here in our case there was no history of fever with chills, so these possibilities could be less likely. Our patient is non-case of pulmonary tuberculosis with tubercular meningitis also, so there might be chances of genitourinary tuberculosis also, but here in this case there is no history of any LURS or urine routine examination in the laboratory examination found to be normal. Other causes include the benign or malignant renal mass can cause right flank pain, but here there was no history of any painless hematuria. Sometimes the adrenal mass or retroperitoneal mass, if it is large, can cause this type of flank pain. So at this point, from the clinical possibilities, we need to rule out the cause of flank pain. We did some radiological investigation in the form of ultrasonography or if required CT scan. So to discuss this radiological imaging, I would like to invite Dr. Dhruv from Department of Radiology.
Good morning, respected dignitaries, faculty members, seniors and colleagues. And thank you, Dr. Asim. I am Dr. Dhruv Adeshara, first year postgraduate resident from Department of Radiodiagnosis. In this presentation, I will discuss the systemic imaging evaluation. The patient case was discussed by Department of Urology for review of prior imaging studies performed at an outside institution. USG and CT done at an outside center. On ultrasonography, shows a well-defined heterogeneous lesion measuring 110 into 90 into 90 mm with no significant vascularity on color Doppler. Liver and right kidney are displaced but seen separate from the lesion. Liver and kidney appear normal in ecotexture and size. No ascites is present and no significant lymphadenopathy is seen. Another lesion is seen in left suprarenal region, which is well-defined hyperechoic lesion measuring approximately 2.9 into 2.9 centimeter here in the left suprarenal region. After confirming lesion in suprarenal region, patient undergoes CT evaluation for lesion characterization. So a large well-defined heterogeneous lesion in the right suprarenal location, which is measuring approximately 10.6 by 9.8 by 9 centimeter with predominantly fat attenuation and the foci of calcification abutting the adjacent liver and displacing the kidney inferiorly. On the same study, the left adrenal gland shows a well-defined low attenuating lesion of a fat density measuring approximately 2.5 into 2.9 centimeter with smooth margin, no calcification and no invasion. Macroscopic fat is seen in both adrenals, makes this bilateral. Based on the above findings, our primary differential is adrenal myelolipoma. This is supported by well-defined lesion with the fat attenuation, lack of absence of vascularity and no surrounding invasion. This argues against the malignancy. The other differentials also include adrenal adenoma, which we consider less likely because on USG it appears homogeneous, which is shows hypoechoic solid lesion with the rapid contrast washout on CT. The another differential is adrenocortical carcinoma, but the absence of irregular margin, necrosis, invasion or any rapid washout makes this unlikely. Then after is exophytic renal angiomyolipoma was also considered, but the intact renal cortex and absence and the adrenal gland is seen separately makes this unlikely. Thank you. I'd now like to invite Dr. Asim from the Department of Urology to carry forward. Thank you.
Thank you, Dr. Dhruv, for giving us the overview regarding the radiological finding. So let's just recapitulate the summary till now that we have 50-year-old male, morbidly obese patient of BMI 47, diabetic, taking tablet metformin BD, on anti-tubercular treatment for pulmonary tuberculosis with tubercular meningitis, presented with the right flank pain since 3 months. On clinical examination, nothing significant. On CCT wall abdomen, there was bilateral adrenal mass, right adrenal mass of around 10 centimeter size and the left adrenal mass around 2.5 centimeter size. So any adrenal mass either is symptomatic or asymptomatic needs functional evaluation. So for this, I would like to invite Dr. Sumegha from the Department of Endocrinology.
Thank you, Dr. Asim. Good morning, respected dignitaries, faculty members, and my dear colleagues. I am Dr. Sumegha from the Department of Endocrinology and will be taking the case forward. So this is a 53-year-old man with a 10.6 centimeter right adrenal mass and 2.9 centimeter left adrenal mass with a BMI of 47 and type 2 diabetes. Clinically, there were no features suggesting a functional adrenal tumor. He had no paroxysmal symptoms, no Cushingoid features, no features of virilization or history of precocious puberty, and was normotensive without hypokalemia, making primary aldosteronism unlikely. There was also no family history or personal history suggestive of syndromic features such as for men to VHL, NF1 or Carney's complex. However, clinical assessment alone cannot exclude hormone excess, as many adrenal tumors are biochemically active despite being clinically silent. Therefore, the guidelines recommend biochemical evaluation before any adrenal surgery. So first we excluded pheochromocytoma, as an unrecognized tumor can precipitate a life-threatening perioperative hypertensive crisis. Because the patient had bilateral adrenal lesions, we specifically evaluated for 21-alpha hydroxylase deficiency, since chronic ACTH stimulation is strongly associated with bilateral myelolipomas and may reveal occult non-classical CAH. Primary aldosteronism was not routinely indicated as the patient was normotensive and normokalemic. So first we excluded pheochromocytoma by measuring plasma-free norepinephrine, and given the bilateral myelolipomas, we did ACTH stimulated 17-hydroxyprogesterone and stimulated cortisol. The stimulated cortisol was 23.6, confirming adequate adrenal reserve, and ACTH stimulated 17-hydroxyprogesterone was 1.36, which was less than 10 nanogram per ml, excluding non-classical congenital CAH and supporting sporadic bilateral myelolipoma. And plasma-free norepinephrines were 123.2 picogram per ml, which were well within the reference range, excluding pheochromocytomas. So finally, the diagnosis was radiologically compatible adrenal myelolipoma, biochemically non-functioning adrenal tumor with no evidence of catecholamine excess, cortisol excess or adrenal insufficiency, or congenital adrenal hyperplasia, no syndromic association. So right adrenalectomy could be performed safely without preoperative alpha blockage. Routine perioperative steroid replacement was not indicated. And for the diabetes management, the oral anti-diabetic drug doses were adjusted for better glycemic control, and plan was to shift on basal bolus insulin once the patient was admitted. Now I would like to call Dr. Devang from the Department of Urology to take the presentation forward.
So quickly summarize this case. 53-year-old male, morbidly obese, diabetic, on anti-tubercular treatment for tubercular meningitis, came with right flank pain since 3 months. Clinical examination revealed nothing significant, and the contrast enhanced CT scan suggestive of right adrenal mass more than 10 cm and left adrenal mass approximately 3 cm. An endocrine evaluation suggestive of non-functional adrenal tumor with no syndromic association. So we took this case to our multidisciplinary team meeting, and after discussion we agreed upon the following plan. So there is no medical treatment, the only treatment is surgery. For the large right adrenal mass, we decided to proceed with right adrenalectomy, and for the left adrenal mass, it did not need surgery at this point, so we opted for the observation and interval radiological follow-up. Before going for surgery, there are some surgical challenges like large right adrenal mass more than 10 cm, due to which we can encounter distorted anatomy, for which we have to clip vein early and require adequate liver retraction. As it is a right-sided procedure, there can be major venous injury risk due to proximity to inferior vena cava and liver, and right adrenal vein is short and directly drained into the inferior vena cava, so meticulous vascular control and gentle dissection is required near inferior vena cava. For patient-specific challenges like patient was morbidly obese, due to which there can be limited access and space. Patient was diabetic, which can lead to the elevated cardiovascular infective risk and poor wound healing. As the patient is known case of pulmonary tuberculosis, there may be pulmonary compromise which can lead to atelectasis, hypercapnia after pneumoperitoneum. So how can we proceed in this case? Our patient is 53-year morbidly obese male with large right adrenal mass. The treatment options were discussed to the patient and the chosen approach was the robotic approach. So why not open surgery? Because higher morbidity and longer recovery, increased blood loss and post-operative pain, larger incision and without any added advantages. So why not laparoscopy? Because limited dexterity in confined retrocaval space, suboptimal precision near inferior vena cava and the major vessels, instrument limitation to fine vascular dissection. So the robotic approach offers the several key advantage in this case. It provides 3D superior visualization in deep narrow space like retrocaval region. Wristed instruments allow the precise dissection around the inferior vena cava, ensuring the better vascular control in high risk anatomy. At the same time, it remains the minimally invasive and promote the faster recovery. So overall, robotics offer the best balance of the precision, safety and minimal invasiveness. So we are grateful to our management for making a robotic surgery possible and helping us provide advanced surgical care. So after taking proper consent, robot assisted right adrenalectomy planned under general anesthesia. So to discuss intraoperative challenges, I would like to invite Dr. Arpit from Department of Anaesthesiology. Thank you.
Thank you, Dr. Devang. Good morning, respected dignitaries, faculty, and my colleagues. I am Dr. Arpit Rai, second year PG resident of Department of Anaesthesiology and Critical Care, and I will be presenting the anesthetic management of 53-year-old male patient with non-functional bilateral adrenal mass and who underwent robotic assisted right adrenalectomy. On preoperative evaluation, the patient had several comorbidities. He was a morbidly obese patient with weight of 130 kg and BMI of 47 kg per meter square. He also had a history of type 2 diabetes mellitus on insulin and had a previous history of tubercular meningitis on ATT for past 8 months. Airway examination revealed malampatti grade 3 with mouth opening of 3 finger breaths, which comes under difficult airway. The patient was accepted under ASA grade 3. So rather than the mass itself, it was the patient's obesity, difficult airway and physiological changes associated with robotic surgery which became the major anesthetic challenges. Our anesthetic concerns were divided into 5 categories. Obesity-related concerns were difficult mass ventilation, limited neck mobility, difficult airway, incidence of obstructive sleep apnea, reduced functional residual capacity, and risk of DVT. Effects due to lateral positions were the dependent lung has increased perfusion but decreased ventilation. The non-dependent lungs get better ventilation but reduced perfusion. There is a risk of brachial plexus, common peroneal nerve, and dependent eye injury. The effects of pneumoperitoneum were reduced venous return and decreased cardiac output, hypertension, reduced lung compliances, risk of atelectasis, increased airway pressures, and hypercarbia. Due to the history of tubercular meningitis and pulmonary TB, there were risks of altered intracranial physiology, autonomic dysfunction, and post-operative pulmonary complications. Due to type 2 diabetes, there was risk of intraoperative hyperglycemia and autonomic neuropathy. Taking all these factors together, our anesthetic plan aimed to optimize oxygenation, manage airway, and minimize respiratory and hemodynamic complications, according to which we defined our anesthetic goals. Our anesthetic goals were smooth induction and difficult preparation for difficult airway, securing minimally invasive arterial blood pressure monitoring, and providing lung protective ventilation. For positioning, it was to provide protective padding and adequate head support, DVT prophylaxis, and managing airway pressures. For maintenance, there were deep neuromuscular blockade, adequate analgesia and sedation, goal-directed fluid therapy, and maintaining normothermia. For emergence, our goal was to ensure complete neuromuscular reversal and hemodynamic stability. I will now briefly describe how these goals were implemented. On the day of surgery, when the patient arrived in the OT, the surgical safety checklist was done, multi-para monitor attached, induction was done by TCI guided propofol in ramped position. Injection rocuronium was used for neuromuscular blockade. Intubation was done with the help of videolaryngoscope and airway was secured with endotracheal tube size 8, bougie guided in first attempt. Two large bore IV access was secured and arterial line was secured. Patient was safely positioned in left lateral decubitus position. Endotracheal tube position was reconfirmed. All pressure points were padded and DVT pump was applied. For maintenance, the patient was provided lung protective ventilation. Normocapnia was maintained. Mean arterial pressure was maintained within 20% of baseline. RBS monitoring was done 1 hourly. Fluid was given goal directed and adequate neuromuscular blockade. Adequate analgesia with multimodal approach. During emergence, the patient was carefully repositioned. We ensured complete neuromuscular blockade with injection Sugamadex. Difficult airway cart was kept on standby with LMA and airway exchange catheter. Patient was extubated when he was fully awake and his airway reflexes were returned. In conclusion, careful preoperative assessment, meticulous planning and vigilant intraoperative monitoring were key to ensuring an uneventful surgical course. Now I would like to call upon Dr. Asim Mansuri to take the case forward.
Thank you, Dr. Arpit, for discussing the intraoperative challenges. So, before moving forward to the surgical step, I would like to explain the anatomy of adrenal gland on the both sides. So, on the right side, the gland is related to the liver superiorly, upper pole of right kidney inferiorly, and inferior vena cava medially. Here, the right adrenal vein is very short and directly enter into the IVC. There are three arterial supply for the right adrenal gland, one from the inferior phrenic artery, one directly branch from the abdominal aorta, and one from the renal artery. In the left side, the gland is related superiorly to the spleen, inferiorly to the upper pole of left kidney, and this on the left side, the left adrenal vein is somewhat longer than the right side, and the arterial supply is same as per the right side. So here, why the right side adenotomies are very challenging? Because of the short adrenal vein. So we have to take care while dissecting surrounding the IVC to ligate the adrenal vein. And here in our case, our tumor is larger, more than 10 centimeter size. So there might be some anatomical distortion. So as earlier discussed by the Dr. Devang, that our plan was robot assisted right adenectomy under general anesthesia. So there are 7 major operative steps, starting from the patient positioning to the specimen extraction. We are sorry that we record a video, but due to some reason we could not able to retrieve it. So challenges start from the patient positioning itself, as patient is 130 kg. So after proper positioning, painting and draping, pneumoperitoneum was created and the 4 8 mm robotic ports were placed. One 12 mm assistant port and another 5 mm assistant ports were placed, and the robot was docked. Second challenge was liver retraction, because here the large liver hepatomegaly. So we incise the right triangular ligament, we elevate the right lobe of liver superiorly to expose the large right adrenal mass. After that, the ascending colon was mobilized medially, coccarization of duodenum done to look for the inferior vena cava, anterior surface of the IVC. After that, we gave gentle traction to the adrenal mass laterally and resect along the lateral border of IVC to locate this short right adrenal vein. Here we have to carefully dissect the right adrenal vein surrounding the IVC, because sometime what happened, that excessive lateral traction on the adrenal tumor or mass can lead to catastrophic bleeding, and we have to convert it to open surgery also. So after carefully identifying the right adrenal vein, we generally clip 3 hemolog clip, one at the side of mass and 2 side of the IVC, and we divide it in between. Sometime we can use robotic vessel sealer also to complete the division. After ligating the adrenal vein, we have to dissect the mass surrounding, and we have to take care of these 3 arterial supply as discussed, that one is inferior phrenic arteries, one from the aorta and one from the renal artery. Generally we use monopolar scissor or the bipolar grasper to complete the division. After that, the large specimen was retrieved in the endo bag. We generally prefer endo bag because the complete end block removal, to prevent the capsular rupture and prevent spillage of the tumor intra-abdominally. After that, hemostasis was achieved very carefully, drain was placed, and the specimen was removed through the right iliac fossa incision and sent for the histopathological examination. So our sir, because this is a very large tumor. If you yes sir, pheochromocytoma, we have to sir first ligate the adrenal vein in the pheochromocytoma. Sir, because we have hormonal release is well controlled if we ligate the adrenal vein first. So there was no intraoperative surge of BP.
He didn't understand the question.
Yes.
In this case where it is a non-functional tumor, why vein first? Why not artery?
Because if we ligate artery first, because of large tumor, there might be chances of avulsion of vein because adrenal vein is very short. So we have to first ligate the vein.
That is the correct answer, that it is a short vein. It is a
left side we can do. So
this is what happens in the exam also. When a examiner asks a question, first you have to understand the question.
Yes sir.
Then you have to give a specific answer. Many a time, most of the time, the students just beat around the bush.
Yes.
Here it was a very specific question.
Yes.
Now what you said was true if it was a functional tumor. Here we know that we are dealing with a non-functional tumor.
Yes sir.
Here the reason is not the hormonal surge. Here
yes.
the reason is technical.
Yes sir. So our estimate blood loss was only 50 ml. Intraoperative time was 150 minutes, and there was no operative complication were noted. So here we are very thankful to our team of anesthesiologists to managing this type of challenging case very smoothly. Patient was extubated well on the day of surgery and shifted to the room. On day 1, oral sips were allowed and ambulation was started. Soft diet was started on the day 2 and the drain and Foley's catheter removal done on the day 3. On day 4, patient discharged with the stable vital and taking full diet. The advantage of minimal invasive surgery like the robot assisted surgery. So now I would like to invite Dr. Neha Jain from Department of Oncopathology to discuss the histopathological examination of the tumor.
Good morning everyone. This is Dr. Neha Jain from the Department of Oncopathology. So basically, an excised specimen of right adrenal mass was received in the Department of Oncopathology, and it measured 13.5 into 12.5 into 6 centimeter. The outer surface was smooth and covered by capsule, while the cut surface was solid grey white to grey yellow. The procedure done was excised specimen of right adrenal mass, and the tumor was located in the right adrenal gland. The tumor size, as mentioned above, was 13.5 into 12.5 into 6 centimeter, and the histologic type was adrenal myelolipoma. The resected soft tissue margins were unremarkable. So basically, this is a low power image of adrenal myelolipoma. Here we can see a well encapsulated lesion. This is the residual adrenal gland. Here we can see the normal trilineage hematopoietic elements, and these spaces, fat spaces, are the adipocytes. This is the high power image which shows the residual adrenal gland. This is the normal hematopoietic elements, trilineage hematopoietic elements in the background, and these spaces are the adipocytes. So the final diagnosis of right adrenal myelolipoma was made. Now I would like to call upon Dr. Subhash.
What is the site of origin of this myelolipoma? Is it in hilum or in cortex?
Sir, it's in the cortex. Its origins from the adrenal cortex.
Adrenal cortex. Which portion of adrenal cortex?
So the fasciculator, basically the adrenal gland gets replaced by these tumor cells, and the residual adrenal gland
is involved, then there should be problem with the sex steroids.
So there will be a decrease in the hormonal production. There might be a decrease in the hormone production, but generally these tumors are asymptomatic. Unless and until they are large, they can create some.
Can you explain the obesity based on your histopathology and
the obesity part?
And the origin? I think Dr. Rajiv Kasliwal can answer it better. There may be shortage of estrogen and other things, and obesity and all those, and other hormones.
So the origin is, it's a hypothesis. The origin is from cortex, and the hypothesis that adrenal gland contains or has primitive reticuloendothelial cells which get transformed into two components. That's why it's myelolipoma, it's not myolipoma. So there are two basic components of those from those reticuloendothelial cells. One is differentiation along the adipocyte lines, which makes fat, and the other is along the myeloid lines, which makes the hematopoietic component. So, and medulla is almost always preserved, though it is compressed, and if we see the sections carefully, it will be seen. However, we cannot, or still we do not know which layer or which part of the adrenal cortex is involved. It is being said generally the origin is adenocortex or cortex. As far as the obesity is concerned, the only scenario where it can happen is when there is a simultaneously what we called as MACS, that is a minimal autonomous cortisol excess syndrome. So that is not there in this case. It was evaluated also. Other than that, sorry sir?
Obesity will be fluid related, not the fat related, isn't it? Because of cortisol, if it is something like that.
The cortisol leads to both excess fat deposition also. So the central obesity is the typical hallmark of the steroid excess. So in this case anyway, so it was a non-functional tumor across all the hormonal lines. The obesity is maybe
So
just a
BMI
bystander.
47 plus, है ना?
So it's a morbid obesity, which is a separate disease.
Thank you. Now I would like to call upon Dr. Subhash Shah for further discussion.
We didn't see any pictures of the gross specimen.
So actually we didn't have any.
Why not? This I have said earlier also. All departments must document, and this is not a common. How many such lesions you get every year? The moment you see when we go on to a tourist place or a picnic, what do? As soon as we see something unusual, we click. Why not in medicine? All clinical departments, all radiology, all pathology, everywhere where there is an image, it must be documented.
ये डॉक्टर जब वीडियो रिकॉर्डिंग में क्या प्रॉब्लम थी सर्जरी? तो किसी रेजिडेंट को बोल देते हो वीडियो मोबाइल से बना लेता आजकल तो यार जैन जी। चलो next time, because such important tumors are there, so a lot of teaching material might be there.
Good morning, respected dignitaries, my seniors and colleagues. Before I start my talk, I want to thank Dr. Neha for conclusion of final diagnosis at adrenal myelolipoma. So now I want to share that we choose this case for today's CCR because this is the rare tumor with size of more than 10 centimeter, and patient was morbidly obese with BMI of 47. And this patient was visited at multiple hospitals with hope with search of the treatment, and came with hope and faith to our hospital, where we able to achieve successful outcome. I sincerely thank to our hospital management for making robotic system available, which has made it possible to perform such complex procedure at an affordable cost under government health scheme. We are proud to say that the cost of robotic surgery at our hospital is among the lowest in the Rajasthan, making advanced robotic surgery accessible to more patients. So this is the evolution of adrenal surgery. The adrenal surgery has evolved remarkably over the past century. It began with open adrenalectomy, which required large incision and prolonged recovery. First open adrenalectomy was done in the 1923. First laparoscopic adrenalectomy was done in 1992, and first robotic assisted adrenalectomy was done in 2001 using Da Vinci robotic system. So the first began with open adrenalectomy, which require large incision, prolonged recovery time, and the later the introduction of the laparoscopic and retroperitoneoscopic adrenalectomy transformed the field of reducing surgical trauma, improving recovery. Today, robotic adrenalectomy offer complex adrenal surgery, safer and more efficient. And I am happy to share that till now we performed 206 cases of robotic assisted surgery, including the uro-oncological procedure.
How many robotic kidney or adrenal you have done? Your department.
Sir,
don't talk of all.
Sir, robotic assisted adrenalectomy we have done 20 cases. till now. And total robotic cases we have done 206, sir.
Only kidney and adrenal you talk.
Sir, exact kidney,
All
urological procedures, 206, sir. And till now we did perform 20 cases of
How many
adrenalectomy.
transplant you have done?
7th, recently we completed 7th case of robotic assisted
Robotic
renal
transplant.
transplant.
How to increase it? Yeah?
Sir, we trying
Too low.
to-
No?
Still, sir, just to complementing the urology department, I think the number seems less in terms of adrenal surgeries, but all of those cases were functional most of the time. In fact, they are paraganglioma or pheochromocytoma, which have a, even in the world literature, though it is being said we are doing it from 2000, but if you go and see the literature, most of the surgeries are being done for benign adenomas kind of a thing. For paraganglioma, the numbers are still on the fingers only. So in that sense, I think urology department needs a big
इसमें तो डॉक्टर
class.
MC मिश्रा जो अपने वाइस चांसलर थे सर्जरी के, उन्होंने फियोक्रोमोसाइटोमा को सर्जरी को काफी
हाँ,
promote किया अपने
sir used to do it
department
with
में.
lab, sir. Yeah.
Laparoscopy.
Laparoscopic. Robotic are the very. In fact, it will, when we have some sizable number, it will be probably one of the at least largest series from the country. Yes, that's another story. Yeah, but if the patient concedes that the obesity is a problem or not, yeah, he should go. But the problem in India, the obesity is very rarely considered as a problem until unless. So he needs to be convinced. Yeah, but people still take it as a sign of healthy or sign of being, doing good.
So looking ahead, the future lie in AI-assisted surgery, fluorescent-guided imaging, and augmented reality and image-guided navigation. These technology will enhance surgical precision, personalized treatment, and may enable scarless or single-port adrenal surgery, ultimately improving the patient safety and outcome. So this is the classification of adrenal tumor. More than 90% adrenal tumor are benign, up to 10% are malignant. Among the benign, most are non-functional, and the most common benign is adrenal adenoma, followed by myelolipoma, and most common malignant is adrenal cortical carcinoma arising from the adrenal cortex, and followed by the malignant pheochromocytoma arising from the medulla of the adrenal gland. So the adrenal myelolipoma, it is rare benign non-functional adrenal tumor composed of mature adipose tissue and hematopoietic element. Incidence is low, and the tumor is usually unilateral and bilateral in up to 5 to 10% case, and most of the tumor detected incidentally on imaging.
Especially sporadic bilaterals are very few. It can be less than 5 or 10 in the literature. All those bilaterals were actually non-treated, long-standing CH patients who develop over a period of time when they are being diagnosed in 30s and 40s in first time, especially male patients, because they will not have ambiguity, simple virilizing without salt wasting, so they will not present with the crisis, so they remain untreated for a long period of time. Sometimes they are being diagnosed in 30s and 40s because of the infertility workups. So there this bilaterality is common, but sporadic bilaterals are hardly less than 10 in the literature. So that is another little rarer aspect of our.
So in my literature search till today, the total reported case of adrenal myelolipoma is 1,231. Among them, bilateral cases were only 40, and the more than 10 centimeter unilateral cases are 25, and more than 10 centimeter bilateral cases reported is 12. The myelolipoma usually associated with obesity, diabetes mellitus, hypertension, and congenital adrenal hyperplasia. So adrenal myelolipoma, most patients are asymptomatic, and this tumor are usually found incidentally on the imaging. However, when tumor grow beyond the 6 centimeter, and patient may develop flank pain or feeling of abdominal discomfort due to its size. In rare case, spontaneous retroperitoneal hemorrhage can occur. Treatment of choice for symptomatic and more than 6 centimeter tumor is surgical excision. Prognosis is excellent, and tumor does not recur after surgical excision. So these are the NCCN guidelines for indication for surgery of adrenal myelolipoma. We follow these guidelines because our case was symptomatic and the tumor was more than 10 centimeter size. So because of the rarity of the tumor, the we able to identify only case report. So there is no case series or meta-analysis that suggesting a rarity of this tumor. And this is our institutional experience. The rare case of symptomatic bilateral adrenal giant myelolipoma published by Department of our Pathology to our university journal in 2020. At that time published. So my take-home message: the spectrum of adrenal mass vary from the benign asymptotic mass to a life-threatening retroperitoneal rupture. So when your patient present with the flank pain, it is essential to include an adrenal mass in the differential diagnosis. So assessment of adrenal mass need proper imaging, biochemical testing, and histopathological examination. So diagnosis of adrenal myelolipoma with radiological imaging with accuracy of more than 90%. So guided biopsy should be avoided, and the management of such case require a multidisciplinary approach to achieve the best outcome. The robotic assisted surgery has revolutionized the surgical outcome and add the value to the surgical skills. So we extend our heartfelt thanks to the Almighty, patient and his family for placing their trust in us, and hospital management for providing the platform and infrastructure. I sincerely acknowledge support and cooperation from the Department of Anaesthesiology, Endocrinology, Radiology, and Oncopathology. I sincerely thank to CCR Review Committee, particularly Dr. S.S. Jaiswal sir and Dr. Lalit Mohan sir for guiding and supporting to organize this CCR. And last but not least, I sincerely thank to my own department of urology, my senior respected professors, my colleague and resident. Their support, encourage, and help in the preparation of 2D CCR team. So now I want to invite Dr. H.L. Gupta sir for brief review of department.
Good morning, respected Emeritus Chairperson Dr. M.L. Swarnkar sir, my respected seniors, colleagues, and dear residents. Today is very special day of Guru Purnima. तो मैं गुरु पूर्णिमा की सबको बहुत बहुत बधाई देता हूँ और मेरे गुरुजनों को, सीनियर्स को तहे दिल से प्रणाम करता हूँ, नमन करता हूँ, जिनकी वजह से आज हम यहाँ हैं और जिस भी मुकाम पे पहुँचे हैं अपने सीनियर्स और गुरुओं की वजह से भी पहुँचे हैं। और मैं अपने पेशेंट्स को जो हम पे पेत रखे हैं, हमसे ट्रीटमेंट कराया, उनको भी मैं प्रणाम करता हूँ, क्योंकि अगर वो हमारे पास नहीं आते तो हम कुछ सीख नहीं सकते थे। तो सबको बहुत बहुत बधाई गुरु पूर्णिमा की। नाउ आई वांट टू गिव brief review of our department. The initially department was merged with general surgery and established independent department in year of 2009, and our journey started with single consultant, and I was doing that part. Now we have team of 9 consultants with 18 MCh resident. We have 2 units in our department. Our MCh Urology program was started in 2026, and initially there was intake of only 1 resident. Since 2020, we have 6 residents per year. At a time, we have 18 residents. Total residents passed from this institute are 22, and they are doing very well in different private and medical colleges independently across the India. We have 3 dedicated operation theatres which work all the time for routine and emergency procedures. And we requested our management that these operation theatres are less by looking our workload. So they consider our request and they are providing 1 more operation theatres in couple of months. Thank you very much, sir. And we would have 4 dedicated urology operation theatres in couple of months. We have different academic activities in our department for residents in form of seminar, general club, interdepartmental meeting, ward rounds, case presentation, and we have monthly theory mock exam. This is team of our consultants, 9 consultants and full-time consultants, 18 MCh residents. These are our department activities. And our residents and consultants regularly attend conferences and workshops and present paper and posters, and different workshops like robotic, RIRS and whole lab workshops were attended. And we try to do regular academic training programs like skill lab endo training for endo suturing, HOLEP and RIRS. And recently we did water vapor therapy workshop, which is REGEM, which is for prostate, but this is only for a small prostate, and in patients they are very ill and advanced age. They are not fit for general anesthesia. And disadvantage of this procedure is that this is suitable only for a small prostate, gram 30 to 35, and the results are not very good as conventional procedures like 2RP and HOLEP, and cost is very high, that is almost 1.5 to 2 lakh. In Rajasthan, Department of Urology are conducting regular yearly master classes, and we were fortunate enough that we conduct second Rajasthan Urology master class in 2024, which was attended around 100 MCh residents and 30 consultants all over Rajasthan, and we are trying to get it in couple of years also. We have independent C-arm. Earlier we were having 50 watt auriga laser, that is holmium. Now our management, emeritus chairperson and chairperson are very kind. They provide us world class best holmium machine of 150 watt, which consists of 150 watt holmium, which is best for prostate surgery, and 35 thulium laser, which is best for stone surgery, which are incorporated in one machine. We have flexible RIRS scope, by which the kidney stones are amenable by urethral route. There is no need to puncture, but this is suitable for small stones. They are size of 1 to 1.5 centimeter in the kidney. We have urodynamic machine, and thank you, sir, for providing us Da Vinci robotic system. All type of surgeries are done in our procedure, from endourology, transplant, uro-oncology, pediatric surgeries. And this is bifurcation of surgeries. Apart endourology surgeries, which are bread and butter for urology, we are regularly doing renal transplant, uro-oncology procedures, pediatric procedures. And by grace of God and help of management, our graph of surgery is increasing every year. This is our renal transplant surgery, which was started in 2012, and till now we have done around 2,700 kidney transplant, and out of which 272 are ABO incompatible and 172 are swab transplants. We have presented around 80 papers in our department, and after inspection, after seat increase from 1 to 6, the number of publications is increasing. Thank you, sir.